All right. Thank you, Natasha. I appreciate the introduction, and thank you, everyone, for joining us tonight. As Natasha said, my name is David Young. I've been the cardiologist at Barton for 12 years, and I'm now the chief medical officer and still participating in our cardiology service line, and I'm happy to speak with all of you tonight. As we thought about different things to talk about, I thought I would go into a little bit about vascular disease and particularly coronary heart disease, because I'm sure that affects almost everyone or their family at some point. So I'm going to talk a little bit about the risk factors for heart disease. I'm going to go over some concerning symptoms when you may want to call your doctor, as well as give everyone some advice on what you can do to stay heart healthy, and particularly relating to some diet and exercise recommendations. All right, so when we talk about coronary heart disease, we all know that heart disease is a leading cause of death for both men and women. Heart disease now counts for about 25% of all deaths, which is about 1 in 4 in the United States. Every year, almost 800,000 Americans have their first heart attack, and another 500,000 almost who have already had one heart attack will have another. So it's not that it's a problem that you have one event and it's cured. It's something that needs to be continually addressed throughout the lifespan. We also know that there's a significant gender gap when we talk about heart disease. We know that the risk of coronary heart disease in women is about a third of that of men, but that kind of begins to negate it when people get to the age of 65 and the rates begin to equal. We know that women in general have a lower risk lifestyle than men, which factors into that discrepancy. And we also know that estrogen can be very protective for coronary heart disease because it can provide direct effect on the blood vessels, which can lead to dilatation and dilation and improve blood flow, as well as improving your cholesterol profile by increasing your good cholesterol and lowering your bad cholesterol. But one caveat, though, is, heart disease in women can be very underrecognized. As we'll talk about later, the symptoms that occur in women can be a lot different than men and go underdiagnosed. So when I'm talking about coronary heart disease or a heart attack, we're mainly discussing blood flow that occurs to the ventricles. The ventricles are the main pumping chambers of your heart, and you have one on the right and you have one on the left. The one on the right, as illustrated here, is responsible for receiving the blue blood from your body and pumping it to the lungs to receive oxygen. The one on the left, which is the main pumping chamber of your heart, receives the oxygenated blood from the lungs and then distributes it out to your aorta, the main blood vessel to your body. Most heart attacks that we're going to discuss involve the musculature of this left ventricle. The heart is a muscle, and like any muscle in your body, it requires blood flow. That blood brings oxygen and nutrients to allow the muscle to function properly. And blood is supplied to your heart through what are called coronary arteries. They arise off of the aorta, the main blood vessel in your chest, and there's both a left coronary artery and a right coronary artery. The left coronary artery supplies the majority of the blood to your heart and has two branches. One is called the left anterior descending artery, which runs down the front, which is otherwise known as the widowmaker. There's a branch called the circumflex branch, and then the right coronary artery wraps around and supplies the majority of the blood to the right ventricle, and then down across the bottom part of the heart where it supplies what we call the septum, which is the wall between the two ventricular chambers. So a normal artery is smooth. There are 3 layers to a normal artery, and it's a smooth vascular structure that allows a conduit for blood to flow through. What happens in heart disease is that you begin to develop cholesterol, which deposits within the walls of the arteries underneath this inner layer of the artery, and it creates an obstruction to blood flow, narrowing the vessel. And these cholesterol plaques that you see right here are inherently unstable structures. So this fibrous cap that's across the top of this cholesterol material can break open. And when that breaks open, it spills all this cholesterol material into the bloodstream, and that forms a blood clot. There are specific cells in your body called platelets which recognize that material within that bloodstream and start sticking to it. That's why taking aspirin or another medicine called Plavix can reduce your risk of heart attack, because the aspirin makes the platelets less sticky and less prone to stick to all that cholesterol material when it spills out into the bloodstream. So when someone has a heart attack, we perform a procedure which is called an angiogram. And an angiogram is an invasive procedure, which most days now people have a catheter which is placed into your wrist, or an IV that's placed into your wrist, and a catheter which goes through that IV up to the heart to take X-ray pictures of the heart arteries. So in this case, here is the catheter, and it is engaged into the left coronary artery. This is the left main coronary artery, which bifurcates into the circumflex, and then the left anterior descending artery. And what we can see on this angiogram is down this vessel, there is smooth flow of the contrast with an equal lumen without any evidence of obstruction. But what we see here is the tapering of the contrast in two segments with almost near occlusion here in this proximal to mid LAD, which is resemblant of the picture that I showed you before of that cholesterol plaque that is broken open and is now obstructing blood flow down the vasculature to the heart. When this is identified, we fix it. And this is originally fixed with a procedure called an angioplasty. And an angioplasty was a process of putting a balloon through that area of obstruction and inflating it to relieve the obstruction. And this was very effective immediately, but what they found is about 30 days after this was performed, the vessel would start to close down again and people would have recurrent symptoms. So they have developed now the coronary stent, which has been around for a long time with multiple generations. And there are two types of stents that are made. One that is just bare metal. And this bare metal stent is implanted over a balloon after they do the angioplasty to keep the artery from reclosing. But what they found with bare metal stents is that this metal is irritant to the vasculature of the inside of that blood vessel. And the body will scar down through that coronary stent over time, and it'll constrict the flow within the stent and start to cause recurrent symptoms. So now most days, stents are what are called drug-coated. And they're drug-coated because they have polymers on these metal struts that prevent the body from scarring down through the stent. Unfortunately, that leaves metal in the artery longer, and those blood cells that I mentioned earlier called platelets can stick to that metal. So now patients, once they have a stent put in, are required to take blood thinners, specifically aspirin and Plavix or a medicine like Plavix, for 6 months to a year to prevent that, to allow healing without the platelets to stick to that metallic structure. So that is the end result of many, many years of untreated risk factors. The number one risk factor, which can lead to heart disease, is high blood pressure. High blood pressure is extremely prevalent in our country, and many of you, almost all of you, may have some experience with high blood pressure at some time. I've seen statistics where up to 80% of people will suffer from hypertension at some point in their life. You can see here that if you have a normal blood pressure at 55, you may still have a 90% residual lifetime of risk of developing hypertension. We define hypertension as a resting blood pressure greater than 140/90. There are multiple things that lead into hypertension. There can be both genetic and environmental factors. We do know that the prevalence increases with age. And the hard part about hypertension is it's an asymptomatic process, unless, of course, your blood pressure starts to move into a range where it can cause things like hypertensive urgency or even emergency. And because it is asymptomatic disease process, it can continue on for a number of years unrecognized and untreated. The effects of hypertension don't just involve heart and heart attack. They can lead to processes called strokes. That same cholesterol process we described before can occlude the blood vessels going to the brain, which is called an ischemic stroke. It can lead to bleeding in the brain, which is a hemorrhagic stroke. It can affect the small vasculature in your eyes, called a hypertensive retinopathy. The high blood pressure can damage the kidney, leading to chronic kidney disease. And it also can cause stiffness and thickening of the heart. If the heart has to keep pumping against this high pressure, it's like any muscle that gets worked out all the time. It gets thicker and stronger. But when it gets thicker and stronger, it gets stiffer. And the only way it can expand to contract blood at an appropriate rate over time is to fill with higher pressure to distend this thickened heart muscle, which can lead to a diagnosis of congestive heart failure. So when we measure blood pressure, I found in my clinical experience that I really like to use home blood pressure recordings because whether you're just rushing into the office or you're nervous about your office appointment or you're nervous to discuss something in cardiology, everyone seems to have higher blood pressures in the office than they do at home. So I always encourage people when you check your blood pressure to do it first thing in the morning. Get up, go to the bathroom because if your bladder is full, that will elevate your blood pressure. And then find a nice quiet area in your house where you can sit, take some deep breaths, and rest comfortably for about 5 minutes. Your arms should be flat, laying on the table in front of you to the elevated level of your heart. And make sure you use a right size cuff. If your blood pressure cuff is too small, it will falsely elevate your blood pressure. And it may do so as much as 15 to 20 points. If the blood pressure cuff is too large, then it will falsely lower your blood pressure. Arm cuffs, in my experience, are usually the most accurate. I've had a lot of variation in readings when it comes to wrist blood pressure cuffs. A couple of important things when you get up: avoid caffeine. Don't have the cup of coffee before you check your blood pressure. Caffeine can lead to some people with blood pressure elevation. And a lot of times people will check that first blood pressure, and whether it's anxiety or nerves, it's higher. Take a deep breath, wait a few minutes, check your blood pressure again. And then in some cases, it may be appropriate to average several of those recordings. So what can you do to prevent hypertension? Well, the unfortunate piece is you can't fight your genetics, not at this point. So some things you can do. Number one, reduce your salt intake. Some people are more sensitive to salt than others. Some people that don't have hypertension can eat salt and it doesn't affect their blood pressure at all. But for most people who have elevated blood pressure, they can be extremely salt sensitive. The more salt you take, the more fluid you retain, the higher your blood pressure would be. Your blood pressure is a function of your flow times your resistance. And by increasing your salt, you increase your fluid. That increases the flow through the blood vessel, which increases the pressure. It's also important to keep your alcohol consumption low. There's a lot of debate about this, and we'll get into this a little later, but certainly any more than 2 drinks at night, particularly at high altitude, can have a negative effect on your blood pressure the following day. Weight loss is important. I tell people in the office, if you can lose about 10% of your body weight, you will have a significant impact in lowering your blood pressure. Exercise, as everyone knows, is important. We'll get into that a little bit later as well. Diet can be extremely important. Eating diet high in fruits and vegetables and low in saturated fats. But if you try all this, if you're reducing your salt, you're keeping your alcohol consumption low, you're achieving an ideal body weight, you're exercising 150 minutes a week, you're having the appropriate diet, and you find that your blood pressure is still elevated, then it's important at that time to call your doctor and start treatment. So here's a little bit about the benefits of lifestyle modification we discussed. As I was talking about weight reduction, I tend to tell everyone it takes about 10% of your body weight to really make a dent in your blood pressure, but the effect can be profound, anywhere up to lowering 20 millimeters off your systolic blood pressure. Reducing your salt, depending on you as an individual, can have up to an 8 millimeter effect on your blood pressure. Physical activity as well, anywhere from 4 to 10 points off your systolic blood pressure. And moderation of alcohol consumption. It's published 2 to 4. I think there can be a more profound effect on that, depending on your level of alcohol intake. So we talked about hypertension as the first risk factor. I think the secondary risk factor, or second most important risk factor in our culture, is sedentary lifestyle and obesity. People with obesity have double the risk of coronary artery disease compared to those that are active in an ideal body weight. As it stands now, at least half of our population does not exercise for at least 20 minutes 3 times a week. And only 22% of the population exercises 30 minutes or more 5 days per week, which is really the current recommendation, is at least 150 minutes of physical activity per week. The hard thing is people will say, I'm going to get in an exercise program, but don't adhere to it. Only about 50% of the people who begin an exercise program stick to it for more than 6 months. So we look at some trends in obesity across the United States. Here's a graph that sort of illustrates 1991, 1996, and 2004. And you can see from the legend on the bottom The light blue represents the lowest levels of obesity, all the way up to red, which represents the highest levels of obesity. And as we progress from 1991 to 1996 to 2004, you can see almost the entire country, particularly the South, has had an epidemic of obesity. And here's the map for 2008. So if we reference back to most of the country being a light blue in 1991, you can see now that we've exceeded the 25 to 29% obesity levels, which were predominantly in the South and the red on the previous map, to now having multiple states with over a 30% obesity rate. And the sad part is it begins in childhood. So this disease process that I showed you of this plaque formation in arteries is not something that you go to bed at 55 with normal arteries and then wake up the next day and you have all this cholesterol plaque in your body. It is a lifelong process. In fact, when they did autopsies on soldiers that would return back from the Korean War, they would start to find the beginning evidence of these fats infiltrating into the walls of the aorta, the main blood vessel in the chest. And it starts with our kids. And we look at the diet of our kids: saturated fats, processed foods, sugar-rich foods, promoting obesity, and starting this process of what we call atherosclerosis at a young age. We also know as a culture that we're just not as active as we used to be. And much of that is because we're inactive at work. We have way more sedentary jobs now than we did in the 50s. Our physically active jobs not only make up about 25% of our workforce, which is about 50% less of what we used to have. And we're less active because we have more technology available to us. We have better mass transportation, and our average work week is longer. People just work more at a desk for longer hours. In fact, we work on average 47 hours a week as a culture, which is about 164 more hours a year than we did 20 years ago. We also have an epidemic of diabetes, and I've overlaid two maps here so you can see how closely correlated they are. So on the top, we have the obesity map defined in 1994, 2000, and 2008. And again, as you proceed from left to right, the lighter shades to the darker shades of red show the increasing rates of obesity. And this is almost superimposed upon our diabetes map on the bottom, 1994 to 2000 to 2008. So directly correlated to our obesity epidemic, we now have an associated diabetes epidemic. So this is risk factor number 3, which is diabetes. Only about 2.8% of the population in 2000 had diabetes, but that's expected to increase to 4.4% in 2030. And most of these cases are what we call type 2 diabetes or insulin resistance. 40% of our US population that's age 40 to 71 has what we call a pre-diabetic state. So their fasting blood sugars may range from anywhere from 100 to 126, sort of in this pre-diabetic range. This diabetes, this pre-diabetes, is again a silent condition like hypertension that causes inflammation with the body, promotes this atherosclerosis process, and is a silent condition placing you at increased heart risk. When people have diabetes, we pretty much equate them to have coronary heart disease because 2/3 of all diabetics will die from a heart or blood vessel abnormality. The death rates from heart disease in diabetics are 2 to 4 times higher than those of non-diabetics. We know that having diabetes accelerates this atherosclerotic process. In fact, when we do that angiogram procedure in diabetics who have heart attacks, like I showed you before, that X-ray picture, we generally find more coronary arteries involved with disease, and the arteries just don't have focal areas that are problematic. They are diffusely diseased throughout the blood vessel. Risk factor number 4 is smoking. The problem with the cigarette isn't just the tobacco, it's everything else that is contained within the cigarette that you're inhaling in your body. And here's just a rendition of all the different chemicals that are contained within a cigarette. When it comes to your heart, smoking is still the most important preventable cause of premature death in the United States. Cigarette smoking by itself, independent of all the other risk factors, will increase your risk of coronary heart disease. And what happens when you smoke cigarettes is that the nicotine will accelerate your blood pressure and heart rate. It causes your arteries to constrict, which leads to damage to the arterial walls. And that damage to the arterial walls increases the tendency for blood clots to form. Smoking also decreases your good cholesterol. You have two cholesterols, a good and a bad. The bad, the LDL, is the one that is responsible for plaque formation in your artery, while your good cholesterol, your HDL, circulates throughout your body, picks up the bad cholesterol particles, and takes them to your liver to be metabolized. The other thing that's harmful about cigarette smoking is that you're inhaling carbon monoxide. And the carbon monoxide competes with your red blood cells to deliver oxygen to your tissues. So you're constricting blood vessels, you're raising your blood pressure, you're raising your heart rate, you're damaging the artery walls, and you're starving your body of oxygen with the cigarettes. So who's at the highest risk that are smokers? Well, it's been published that women who smoke and use oral contraceptives greatly increase their risk of coronary heart disease and stroke compared to non-smoking women with oral contraceptives. Cigarette smoking combined with a family history of heart disease, and even a social smoker who says, oh, I only smoke a little bit, like 2 to 4 cigarettes a day, that can still have a twofold increase in your overall risk of heart disease. Does it matter what I smoke? Well, some people will say, well, I only smoke a cigar or a pipe, and there can be oral cancers and problems that are associated with that. But there's little scientific evidence that relates that to cardiovascular disease. And I always get this question asked to me, and I don't have the data to tell you or regarding the long-term effects of marijuana smoking. Well, what about secondhand smoke? Well, secondhand smoke can increase your cardiovascular risk just as much. About 70,000 deaths per year are labeled to exposure to secondhand smoke. But here's the good news about quitting smoking. I tell the patients, when you quit smoking, after 1 year, your heart attack risk decreases by 50%. And if you can stop smoking for 15 years, your risk equates to those of a lifelong non-smoker. So it's never too late to quit, and you should quit as soon as you can. People always ask me about nicotine replacement therapy. Most patients with heart disease can safely use patches, gums, sprays, or inhalers. The amount of nicotine that is contained in these products is about 1/3 of what you're receiving for a cigarette. And I always advise people that I'd rather have them on nicotine replacement therapy withstanding vaping than to be an active cigarette smoker. So let's go into our next risk factor, which is cholesterol. I mean, cholesterol is one of the main products of the main product of what's packed into the blood vessel wall to cause these obstructions. And your cholesterol levels in your body are a function of two things. One is what you make, which is usually genetically controlled. The LDL, your bad cholesterol, is made by your liver. You also receive cholesterol in your body by the food that you intake. It's anywhere from 25% to 40% dietary and 60 to 75% for what is broken down, formulated in your body. I'm going to skip this. There are certain guidelines that are published for cholesterol lowering therapy. I think the only thing to remember out of this is lower is better when we talk about LDL or bad cholesterol. Family history, risk factor number 6. So when we talk about family history, it's really hard in the office because I'll ask a patient, well, do you have a family history of heart disease? And everyone does. Everyone has someone, an aunt, an uncle, a grandparent that has had some type of stroke, heart attack, because it's the number one killer in that age group. But these are the people that I really try and identify those at high risk. A first-degree relative, so mom, dad, brothers, and sisters, who had a male member with a heart attack under the age of 55 or a female under the age of 65 is identified as a increased risk of a family history. But it's also really important to know, are they diabetic? Are they not diabetic? Were they a smoker or non-smoker? Because this can influence it. Hopefully in some time, we will have more genetic sequencing and genome mapping where we can start to send in cheek swabs and map out and find specific genes that are associated with increased cardiovascular and family history risk. But for now, when you think about your own family history, did I have a male relative, first degree relative under the age of 55 or female under the age of 65? So that's coronary heart disease. We talked about the process of what we call atherosclerosis occurring throughout the lifetime, the plaque formation that occurs in arteries, which can lead to obstruction. And that plaque can break open and cause a blood clot in a blood vessel, which leads to a heart attack. We showed the angiogram of what that looks like. We talked about the risk factors of hypertension, diabetes, obesity, smoking, high cholesterol. What happens when what are the symptoms that I should recognize to indicate that I may be having a problem with my heart? Well, the first is obviously chest pain. And the chest pain that we attribute to a heart is called angina. But it's not really pain that people describe. It's more of a squeezing, tight, pressure, heaviness sensation. Some women have described to me that they feel like the bra is too tight fitting, that type of constriction band-like process. The discomfort can be anywhere. It can be in the middle of the chest. It can be down lower in what we call the epigastric region. It can be in the neck, the jaw, either arm, or between the shoulder blades. Typically, these symptoms are exacerbated by things that elevate heart rate and blood pressure, anxiety, activity, emotions, and even eating. And they're generally relieved by rest or a medicine which is called nitroglycerin. Nitroglycerin is a small tablet that people place under their tongue, which dilates blood vessels and restores blood flow to the heart. This chest pain or angina may also have some associated symptoms. People can suddenly feel short of breath, they can feel nauseous, they can feel cold and clammy, and they can have an overwhelming anxiety sensation. Some people just get breathless. So they'll say, God, I did this physical activity a week ago, and now I just can't catch my breath doing the same amount of exertion. This decrease in exercise tolerance they describe. Or some people just say, wow, I'm just getting so fatigued easier and easier. It's just not normal. And that can also be an indication of problem involving the heart vasculature. Here's some important caveats I want you to remember about that. Women typically have very atypical presentations of heart disease. They don't always come and tell me that they have the pressure, tightness, heaviness in their chest that we classically would associate with it. Sometimes it's just the fatigue, the lethargy, and the decrease in their exercise capacity. Also, diabetics, because of the way that the blood sugars can affect nerves, may not experience chest pain. They just may have the shortness of breath, as we described above, but sweating, nausea, and that can be a warning sign. I want to talk a little bit about the Western diet, because a lot of this has been associated with the obesity epidemic, the diabetes epidemic, and the risk of heart disease in our country. The American diet involves a high intake of fried foods, saturated fats, as you can see here with onion rings, French fries, burgers, and ketchup. In fact, people like to even dramatize this. This is actually a restaurant with multiple chains across the country where you can get a burger, which can either equate to a single bypass, a double bypass, a triple bypass, or a quadruple bypass burger. So you can have a burger associated with the meat, the saturated fats, top that off with a milkshake, fries, some candy, and hose all of that down with a Coca-Cola and a cigarette. So people always ask me, what is the best cardiac diet? And I think that there's so much data out there regarding diet, and by no means am I an expert in all the different type of dietary patterns that are out there. But geographically, if you look at the difference in the incidence of heart disease, you can see that there are two areas where this is extreme, where heart disease is low. And one is the Mediterranean region, and the other is the Pacific Rim. And heart disease in these areas can occur at a 50 to 80% less frequently than they do in Western states. And why is that? Well, their diet is simply an abundance of fresh fruits and vegetables. They eat whole grains and complex carbohydrates as opposed to the stripped down simple carbohydrates that we have in our diet. They use way less refined sugar and processed foods. They have fish and poultry consumption as opposed to red meat and hoofed animal products. They use olive oil instead of butter. They use low to moderate dairy products such as cheese and yogurt, rare red meat consumption, and moderate wine consumption, usually with meals. Does it work? Well, I think the answer is yes. There was a Lion Diet Heart study that randomized 605 men and women with prior heart attack to a modified Mediterranean diet versus, a prudent diet that they were continued on what they were doing before. And they found those that followed the modified Mediterranean diet had 72% fewer cardiovascular events and 60% fewer deaths. So why is it so protective? Well, a lot of it has to do with the fat intake. You're substituting these polyunsaturated fatty acids, these omega-3, these omega-6 fatty acids for the saturated fats, the butter, the beef, the solid fats at room temperature. Some general recommendations for diet is to increase consumption of omega-3 fatty acids from fish, fish oil supplements, and plant sources. You want to get rid of the saturated fats and particularly avoid trans fats at all costs. Consume a diet high in fruits, vegetables, nuts, and whole grains, and avoid sugar and refined grain products. One last thing I'd like to mention about diet, and there's not a slide in here to support this, that some of the most beneficial data that we have for reversal of heart disease or prevention of heart disease or secondary prevention of heart disease has to do with the whole food plant-based diet. And for a while here at Barton, we had a program called the CHIP program that we used to enroll people in with cooking classes and coaching. And we're looking in the future to help bring some of these programs back associated with cardiac rehabilitation to help support the members in our community. I want to touch on alcohol a little bit because this can be a very controversial subject with people. There's all kind of literature out there that red wine can be good for your heart and a little bit of alcohol is good. And what they found is that the potential beneficial effects of alcohol can have a couple of things. One is it can lead to some what we call vasodilatation or a dilatation of the blood vessels, and that can reduce pressure in the vessels. We know that there's a little bit of an increased production in your HDL, your good cholesterol associated with alcohol intake, and it has a little bit of a blood thinning effect. Remember, the process of a heart attack can be is blood clot driven. But the effects of alcohol are really in very mild amounts, 1 to 3 drinks per day, depending on female or male and body habitus. The protective effect of alcohol, if there is one, and that is again debatable, really diminishes after 2 drinks. And it turns out that the type of alcohol really doesn't matter as long as you're staying within what is described as a 1 drink quota. Moderate and daily consumption of mild amounts of alcohol have shown better benefits than those who engage in binge drinking. What's the downside? Well, this is all really based on observational data. There are many other downside effects of alcohol other than the potential mild cardiovascular benefits such as alcoholism, liver disease, and we've already discussed the effect that alcohol can have on hypertension, one of the known risk factors for coronary artery disease. It also impairs your motor skills and judgment, which can lead to other type of harmful outcomes. And its benefits may be, as we know, limited to certain individuals with specific genotypes or genetic makeup, not universally to everyone. I want to talk a little bit about exercise now. So we're just going through things for cardioprotective events. We've talked a little bit about diet, the Mediterranean diet, a whole food plant-based diet, avoiding the Western diet, high in saturated fat, processed carbohydrates, and sugar, as well as salt. We've talked a little bit about some potential beneficial effects of mild alcohol consumption, although most of the time we're worried about the harmful effects and minimizing alcohol intake, particularly for blood pressure effects. And now we're going to go into exercise. The current minimum recommendations is that you get at least 150 minutes of moderate exercise per week. But you don't have to do that all at once. It's not something that has to be, every day, 30 minutes. This can be broken up throughout the day. And those activities, such as a brisk walk with your friends, can count as part of that exercise. It doesn't always have to be a structured, high-intensity class. Walking, jogging, swimming, biking, those can all have cardioprotective effects. They do recommend that in that 150 minutes, you have a couple strength and stretching exercises that are part of that program as well. The benefits of physical exercise: even moderate physical exercise provides a risk in your overall risk reduction of coronary heart disease. Whether you are just doing this for primary prevention, which is meaning you've never had an event, or for secondary prevention, which means you've had an event and you're trying to prevent another from happening. The more physical exertion you do, the more cardioprotective the risk is. The program I mentioned before, cardiac rehabilitation, which we are actively working to bring to Barton, can, through its physical exercise, dietary processing, nutrition counseling, provide an overall 20 to 25% reduction in cardiovascular mortality, most of that being secondary prevention. So in conclusion, I want to leave everyone, be aware of your potential risk factors. Pay attention to your blood pressure, pay attention to your diet, your exercise level, your body habits, have your cholesterol checked, monitor your blood sugar, don't smoke, minimize your alcohol intake. All of these risk factors accumulate in your body over time, which can substantially increase your risk, heart attack, stroke, cardiovascular death. It's also important to know your family history. If you're one of those individuals that has had a first-degree male family relative with a heart attack before the age of 55, or female less than 65, you're at a genetically increased risk for heart disease. Follow up with your primary care physician. Your screening annual wellness visits, your routine annual physicals are very powerful tools to identify these risk factors, many of which are asymptomatic, to help modify them to prevent these long-term complications. And most importantly, don't ignore these symptoms. Chest pain, chest pressure, progressive shortness of breath with activity. All of those can be serious signs, symptoms that something is wrong with your heart. The hard part about a heart attack is about 50% of the people that have their first heart attack don't survive it. And a heart is not something you can give back. So once the heart muscle is destroyed with a heart attack, it's gone, never to return. I'll also leave you with the fact that we're here to help. Our cardiology division, everyone here at Barton Health we're here for your health, your wellness, your well-being, and happy to help at any point as we can. And I think with that, I'll stop, Natasha, and be available for any questions that may come up.
Great. And you can keep sharing if that helps.
You want me to end sharing?
Yeah, since it's a black screen. If you have any questions, you can ask them in the Q&A. But I'll just start off. And by the way, the Q&A box is located at the bottom of your Zoom screen, where you can ask in the chat box. But just wanted to know if you wanted to speak a little bit to kind of future programming for Barton's cardiovascular service line.
Right. Well, I think everyone knows we've had a little bit of disruption in our cardiovascular service line, and a lot of that has come as I've transitioned out of my role as cardiologist into chief medical officer. And we are actively working in building our cardiac program, recruiting another cardiologist. We have added 2 nurse practitioners. Many of you may have met Holly Burnham, who works in our division, and we also have just signed on Tanya Dixon Humphreys, who's another great addition to our program. And we have big plans for cardiology. We're expanding the services that are available at Barton. We're expanding our echocardiogram services. We will start doing procedures such as stress echoes. We're going to build cardiac rehabilitation programs. And as we expand into the new hospital, one of the things that I'm most excited about is the space, the increased technology access that we will have in this new facility to provide better diagnostic imaging, chest pain centers, more acute cardiac care. We're also working to expand our ICU so we can keep people who have heart attacks so they don't have to be transferred to Reno, they don't have to be transferred to Carson, and they can stay in the community.
Great. The first question, are frequent PVCs related to heart disease?
They can and they cannot be. So a PVC is just an electrical signal that comes from the bottom chambers of your heart. And your heart runs on electricity. So it's this passage of electrical current that causes the muscle to squeeze. And a PVC is just an extra electrical impulse coming from outside of the heart's normal electrical system arising from the ventricles. And PVCs can be entirely benign. In fact, everyone has some degree of PVCs during the daytime, or they can indicate that there's a problem with the heart. So if you have someone that has frequent PVCs, which we see not uncommonly in cardiology, then you should have a diagnostic workup to look at that. And that will usually involve wearing a heart monitor to determine how many PVCs you have, make sure that you're not having a bunch of PVCs in a row. And then you'll have something called an echocardiogram to look at the structure and function of the heart to make sure there's nothing anatomically that's driving that. And then, of course, you will have a stress test of the heart to make sure that it's not a blood supply problem in the heart that's causing this electrical instability. And depending on what comes out of that workup really defines whether it's a benign nuisance problem or whether it could be something that has a more serious outcome.
Great. The next question is, any suggestions on alternatives to statins if your cholesterol is borderline, such as citrus bergamot?
The ones that I have found that have been very effective for cholesterol, well, of course, diet, right? So your bad cholesterol comes from saturated fat intake in your diet. So as much as you can avoid saturated fat and follow a whole food plant-based diet with limited oil intake, I've seen profound drops in people's cholesterol with that. So I would say that's the number one most powerful thing. The other supplement that we have used with variable suppressed is red yeast rice. So red yeast rice contains a component in it called a monocolin, which is molecularly similar to lovastatin, which is one of our cholesterol lowering drugs. And if you can find the right preparation of red yeast rice, I have seen people be able to drop their cholesterol with that. Well, everything in medicine has risk and benefits, and statins are like one of the most polarizing medications in cardiology. There's like really toxic antiarrhythmics that we have to use for people's hearts, and no one ever says anything to me about that. But whenever I bring up a statin, it's like a big uproar. And I just ask people to approach it with a risk-benefit analysis. The risk of statins that I have seen is about 5 to 10% of people get muscle aches and joint aches. There are some concerns about it elevating blood pressure, particularly at higher intensity doses. Lipitor, Crestor at higher doses can elevate blood sugar. I've never seen cancer associated with it. I have had one, maybe two people in my practice who have had some short-term memory loss from Lipitor that reversed when I stopped it. But always look at the statins and say, okay, well, what is my risk of heart disease? If you've had a heart attack and you're taking a statin, it can reduce your risk of recurrent heart attack by 40%. If you're at high risk, taking a statin for primary prevention can reduce your risk by 25%. So approach it like that. Don't believe everything you hear about the medications on the internet. Look at your individual risk. Look at the risk of the medication, the risk of the heart disease if it's left untreated. But that's just me on a soapbox about statins. If you're looking for supplements, I would take a look in the direction of red yeast rice and see if that may be beneficial for you.
Great. The next question, since you mentioned weight loss is something that people should consider to improve their heart health, what is your opinion on the weight loss injections?
Yeah, it's funny. We were talking about this. We were talking about wellness lecture topics, and I said, man, I should really go into the injectable medications because it's such a rave out there. I mean, every time you watch TV, it's either, an Ozempic or Zepbound commercial. And I think that the weight loss drugs can be effective in reducing overall cardiovascular risk by the weight loss. I'm just a little bit scarred personally by the number of patients that have done it and had gastric motility or intestinal motility disorders after it, which have not been reversed. So, I'm a little hesitant to make a blanket recommendation for those medications. I do think they're very effective in weight loss, and we know that weight loss is tied to cardiovascular risk reduction. I'm just a little concerned in my clinical experience with some of those outcomes that I've seen.
Great. I think we've covered the questions I've seen come in. If you have one though, feel free to enter it and I'll get it for you. But I'll just start to wrap things up. We did record this presentation tonight, so if you want to go back and rewatch it, it will be on our YouTube by tomorrow. And then we have just a follow-up survey when you exit this Zoom presentation. We would love your feedback and ideas for future presentation topics. I'm just perusing again, and I don't see any other questions come in. So I think we'll go ahead and wrap it up. Thank you so much, Dr. Young, for being here tonight. We appreciate it. And I hope everyone stays warm and dry out there with all this weather. Have a great rest of your night.
All right. Thank you, Natasha. Have a great night.